All right, everyone, good afternoon. Just keep grabbing your food and take your seats, but we're going to get started here. So today, the Center for Excellence in the Neurosciences, the Department of Biomedical Sciences, the AMOPS Club, and the WADM Clubs are all happy to welcome Dr. William Bograkos. Now, Dr. Bograkos, or as many of you know him like me, Colonel Bograkos, graduated from the University of New England and went on to get board certifications in both family medicine and emergency medicine. Dr. Bograkos graduated from the U.S. Naval War College in 2009 with distinction, and then went on to receive his master's in national security and strategic studies in 2011 with distinction. So he's got a lot of education. Among his many projects and achievements over the years as a physician, Dr. Bograkos served as the medical director for the Neuro-Restorative National Capital Area, looking specifically at severe traumatic brain injury, continuity service at Walter Reed Military Medical Center in Bethesda, and for HomeMind, which is the Danish version of Wounded Warrior Project. These topics are precisely what he's going to talk about with us today in his talk entitled Homecoming, Traumatic Brain Injury, and Psychological Health. So please join me in welcoming Dr. or Colonel William Bograkos.
Thank you, Matt. Thank you, Matt. Can you hear me? Okay. I appreciate the opportunity to be here. I think we're live streaming to the WADM as well, so I appreciate the Military Club and the WADM Club, the World Association for Disaster and Emergency Medicine. The WADM Club here is the only club of this international organization. So to our colleagues in Australia, I'll be speaking from New England, I'll be speaking in New English. The way I like to talk about this homecoming is I reflect on Homer. Do you all remember reading Homer? Good, a lot of nods. Right, so when we think about Homer's Odyssey, we think of what character? Ulysses. You think of Ulysses, I think of Odysseus, right? Same. So something that we don't really think about until we deploy is that Odysseus came home alone. Ulysses, Odysseus deployed with all his comrades, soldiers from Ithaca. And so the Iliad is the story or poems of death referring to pre-deployment and deployment. Something to think about. Something to think about because I don't think the nature of man has changed in 3,000 years. Technology has changed, but the nature of man has not changed. So I'll try to focus on traumatic brain injury. Nowadays, when I talk about TBI, I think about traumatic brain injury, but I also think about toxic brain injury. When you have chest pain, your brain takes you to the emergency room. When you have a head injury or a head illness or traumatic brain injury, toxic brain injury, your brain is not taking you for help. Something to think about. That's the challenge for you as young physicians. And of course, I'll be speaking about psychological health. As Matt mentioned, I graduated from here when this used to be a gym, and went on into the military. 10 years with the Air Force, 18 with the Army, and Naval War College graduate. And my graduate work was actually in narco-terrorism, and that's how I ended up as the president of the Addiction Medicine Academy. So, well, I'm not receiving any funds from pharmaceuticals, not receiving any funds from the cannabis industry, not receiving any funds from the mob. I'm not receiving any funds from the Russians. I'm here, and I'm not a psychiatrist, but I am a consultant with trauma recovery because of my operational experience and because of my experience in trauma rehabilitation. So, first slide. For my colleagues again in Australia, lecturing from Maine. This is what we drink up here. Moxie. The objectives, my objectives, our objectives is to try to understand military medicine. Understand military medicine because these are your people. There are 1.2 million veterans in New England, in the Red Sox nation. We have to understand their deployment, their trauma, and their homecoming. We also have to have an idea, understanding of integrative health systems. I know you're all here and you're all trying to get residencies, and you're kind of thinking silos, but in order to take care of your patients, to be patient-centric, we have to be thinking integration. Integration is important for pain, it's important for traumatic brain injuries, integration is important for, I think, everything as we get older. The other part too, another objective is to talk about traumatic brain injury. It's very important to talk about civil-military cooperation, collaboration, communication. And the term that you really have to be thinking about, it's not a board question, but the term that you have to be thinking about is interdisciplinary. Anybody want to comment on that? You want to talk about interdisciplinary as opposed to multidisciplinary. Multidisciplinary is when I'm a family physician and I'm getting a consult and I get a consult back and I do what the consultant tells me, as opposed to doing what I think is right for the patient I know. Interdisciplinary is when we're working as a team, right? Team. Together, everyone achieves more. So patient focus, patient focus. Okay. First slide. When we talk about military medicine, we have, well, the history of military medicine, we do have to be thinking about military history. Anybody read Clausewitz yet? Anybody use Clausewitz to take care of a ganging cyst? It's a big book. It's a big book. Clausewitz talks about On War, 1832. So Clausewitz writes about On War, and he talks about two fighters. In that time, he's talking about two Greco-Roman wrestlers, right? And at that time, he's talking about open battlefield, European battlefield, equal weight distribution, if you will, equal skill, equal fighting spirit. But that's not the way things happen. Today, what happens with irregular warfare is the IED, irregular warfare, improvised explosive devices, right? Signature injury of the war is blast injury. Okay? So we have to pay attention to the medical journals and to military medicine and to medical education. The media educates the country, or the media informs the country, but we have to pay attention to search for truths. So shifting from two wrestlers, I need to talk about two pugs, two pugilists. So as a ringside physician, you're at the ring, right? Close to the ropes. You can get under the ropes, take care of your fighters. And you have eyes on two fighters, not two wrestlers, two pugs. And here we have some regs, some regulations. If a fighter gets dinged, and his hands drop, his or her hands drop, as a ringside physician, amateur boxing, call the fight off. Why do you call the fight off? Because if he's dinged, stunned, he's a Glasgow of 14, 13, at least. Call the fight off because that fight is going to get hurt. And it's not worth it. Because that risk, the risk that you're worried about on the top of your differential is, anybody want to comment on that? What's the risk? Well, he already has a concussion by being dinged. Oh, that's good. We made eye contact, so I'm going to move over here. Right. So what you're talking about is chronic traumatic encephalopathy. So before we go down that road of CTE, the really bad consequence is second impact syndrome. So we had Ray Ciangaleri come up here a couple years ago, and I think we should bring him back. Because if you go to the second impact syndrome, which Ray drives, second impact syndrome is what? You had neuro and psychiatry already, right? Are you, what? How many second years did? So remember in neuro, so remember in neuro, right, when you talk about second impact syndrome, you talked about dysfunction in autoregulation. Second impact syndrome, if you send a fighter back in that time period, well, it's easy for a ringside physician. You get dinged, I write on your card, no ring, no fighting, no contact, 30 days. For that ding, I'm not even talking about the knockout. So for that ding, no contact, 30 days. I write it. And the coaches, trainers, they don't let them go in the ring. So with the second impact syndrome, you have dysfunction in the autoregulation and brain swelling and herniation, right? So kind of basic stuff right now. So the reg here is time. You see the ding, you see the knockout, kind of. Not dinged, down, not, it comes up. They're coming up, right? So what am I talking about? I'm talking about the mild TBIs right now, okay? So the fighter gets dinged. Okay, my job, make sure, do no harm, take care of that brain. I'm worried about second impact syndrome. I have regulations. You don't have the same regulations in football, do you? And oh, by the way, or soccer, or other contact sports. So, and oh, by the way, you're at the sideline. You're not at the ring. Something to think about as sports medicine physicians. Is the sports medicine club here too? A few people from sports med? In sports med, who you want to read is Dr. Cantu from Boston, right? This is an old slide, but this is background, historical. So people might criticize me for having old references like Homer or this. So when we talk about here, now we're adding something different. We saw the fighter go down, and now what are we adding that we're looking at in part of our medical history? What? Yeah, but I'm talking about, right now I'm talking about you're a sideline physician. So yeah, history of prior head injury is good in the office as family physicians. Good for you. Good for you. With this slide, what did I add to this slide? I added PTA. I'm not talking about Parent-Teacher Association. I'm talking about post-traumatic amnesia. So you had a fighter that got dinged, and what's more important than the ding is now the dimmer switch. Ding, lights out, but we need to focus on the dimmer switch. Dimmer switch is really more important because the dimmer switch, or the post-traumatic amnesia, has to do with your circuitry, has to do with laying down new memories, and memory, and learning. So now we're starting to talk about neurocognitive domains, right? You went over that in the DSM-5? Right, so PTA is very important. Something here, so we're looking at grade 1, grade 2, grade 3, which we don't talk about now, but that's history. But when we look at that grade 3, post-traumatic amnesia greater than 24 hours, now for language, that's a moderate TBI, all right? So when you go on rounds and when you look at histories from other people, and people are saying, oh, he had a mild TBI, or a patient comes to you, right, a player or and any patient, any history of concussion, traumatic brain injury. Important question is, when did you start to lay down new memories? PTA. Again, think of it, ding, and now dimmer switch. Now, I use that question quite a bit in psychiatry. I use that question when I'm talking to troops about their medications. How do you feel? Where's your dimmer switch? How do you feel? And it's important in return, obviously return to play, athletics. But we're a bit complicated. It's a bit complicated. You've gone over the Glasgow Coma scale, right? So the highest is what? Go ahead. Hey, we can have dialogue. The high, 15, right? And the lowest is what? Yeah, 3. So 3 is a trick question. It's a board question, 15 to 3. It's not 15 to 0, it's 15 to 3. Challenge here with Glasgow Coma scale, we're always reporting this from the emergency room, right? The patient's moaning, and when the patient's moaning, this is a moderate TBI. Do the math. When you first look at the Glasgow Coma scale, you're looking at the math, you're doing the math. But up here, when you're looking at this, patient moaning for verbal, V, 5, highest you can get is 5. That's a moderate TBI. The challenge here for athletics, but more so on the football and battlefield, is that person who's walking, talking. So walking, talking, you're 15, 14, 13, walking, talking. What do you do now? That's the challenge. And what do we do in football? We use what do we use in contact sports? Anybody? Nobody? Sports concussion assessment tool, which is what a MACE is. The MACE is what your medics use on the battlefield. A MACE is a sports concussion assessment tool. Here, when you look at the MACE, what happened? Do you understand what happened to you? Memory. Oh, by the way, mechanism of injury, very important. It's important on the battlefield. I've seen young soldiers who said, who have guilt because they froze after their vehicle hit an IED. Doc, I froze. I didn't return fire. You had to talk to him. You didn't freeze. You were concussed. Think about that. Think about lifting that guilt off. Mechanism of injury, right? Amnesia before, after, antegrade, retrograde amnesia. And with number 8 here, symptoms. Those symptoms are what? Those symptoms are post-concussion syndrome, right? Okay? Again, documentation in the field. And again, now we're going to we touch upon your neurocognitive domains. Do you remember them? No? So, what? Oh, you haven't learned them? Oh, okay, so I'll pick on you. Where's the second years? Up here, the front? So, no, I'm just teasing you. So when we talk about, so now we're touching about neurocognitive domains, right? We're touching upon it. I like to think about this. The DSM-5 is vast, but that's my first chapter. I like to have I like to be strong in neurocognitive domains. So complex attention, right? You focus. And then executive function, right? Executive function, any prior service people in here? Prior service? No? So executive function, your life is your operational plan. Then language, then psychomotor, right? Then we have social cognition. Did I leave anything out? learning and memory, okay? So these are some things that you check, think about. This is what we're touching upon: immediate memory and concentration, complex attention. Very quickly. And then a little bit of memory or recall. So again, when we're talking about, when we're utilizing language across lines, how many people here are going into physiatry, neurology, family medicine? No one. So when we discuss brain injuries across disciplines, and people talk about mild TBI, moderate TBI, severe TBI, this is important. So looking at this slide, if you have someone with a mild, well, if you have somebody with a Glasgow-Coma scale of 13, but a PTA greater than 24 hours, how would you describe that person? You would describe that person as having a moderate TBI, okay? Remember, PTA is the circuitry. It's very important. Post-traumatic amnesia is very important because now the patient's going to be frustrated, anxious, compensating for this, potential to self-medicate. All right, have you had OMM yet? So you've had OMM, you have the history of OMM too, right? So who is this man? That's right, there's a clue. Major Andrew Taylor Still. So Major Andrew Taylor Still, what conflict was he in? Yeah. While you're here, you need to talk about the history of osteopathic medicine. So when we think about Andrew Taylor Still, you have to remember that he was a major in the Civil War, our Civil War. And you have to think about what he saw. Obviously, he saw a lot of penetrating trauma, right? But we don't think about all the infectious disease. We do not think about all the infectious disease to include gangrene. So think about that. Think about him. Think about his homecoming. Think about his homecoming. Think about him thinking about lymphatics. You're the next generation. You need to be thinking about glymphatics, right? You've talked about glymphatics in neuro, correct? Glymphatics. You've talked about craniosacral rhythm? What? Second year? But anyways, you need to be thinking, keep that word in mind. You need to be exploring glymphatics. Glymphatics help your brain move out the tau, the amyloid, the ADP. Glymphatics. Think about that. Also, A.T. Still, when he talks about anatomy, you've had anatomy, right? First years. And in the cranium, what's up front? No, I'm talking about bone right now. What are those crusses? When you think about the sphenoid, and when you think about open up the cranium, when you go back to the lab, open up the cranium. Look at your anatomy and look at the sphenoid. And then look at the frontal. And then think about head injuries and shearing. Think about your tofu brain moving, having a shear in the front. Think about your orbital frontal lobe, and your frontal lobe, and your frontal temporal lobes, and think about impulsivity. Think about impulsivity, amotivation, personality, executive function, complex attention. Think about that. Because that's what we're talking about, right? But I'm here, I'm an older guy, so I'm here helping you try to put it together. You have the cranium, you have a shear, Doesn't matter if it's blast or blunt, there's a sharing. So don't be surprised when your patients become impulsive, frustrated, having difficulty with executive function, and don't be surprised when somebody who's drinking has a head injury, then has a problem stopping drinking because of his impulsivity. That's structure and function. But what I want to get to here with AT still in the battlefield is I want to talk about the structure of the battlefield for just a little bit of time. These military guys have already had this, but for you, for the non-military people, what we're really talking about is emergency medical systems. A linear battlefield, right? So far forward, you don't have surgical capability. When you look at echelon 2, that's when your surgical people are there, right? Because trauma, right? And echelon 3 is when we start to have hospitals. 4 is what you think of when we think of long stool. And 5 is CONUS or continent United States. Balboa, Bethesda, Walter Reed, etc. Okay with that? The image there, the image is there to get a thought process or a concept on EMS. It's EMS. This is, we're the Wadham students over here. So regarding, this is a man-made disaster, right? War is a man-made disaster. So on one side you have pre-deployment, deployment. On the other side you have post-deployment. You have pre-deployment, deployment, the Iliad. Characters in the Iliad, anybody remember? Give me one. Right, good. So one character, Achilles. Everybody remembers Achilles, but no one remembers Ios or Ajax. So Achilles was the greatest warrior on the battlefield. Well, the greatest the Greeks had on the battlefield. And Ios, no one really remembers Ios, but Ios is a good example of a warrior. When Achilles was killed, Ios had great grief because he lost his battle buddy. Then Ios had great shame. Why? Because the commander, Agamemnon, gave Achilles battle gear or shield to Odysseus. And when we think about suicide, military suicides, Army suicides, 1/3 never deployed, 1/3 during deployment, 1/3 post-deployment. But what's common is guilt and grief and shame. Anyways, this is the dynamics of disaster. All right? From this conflict, from current conflict, we've had a surge of survivors. And what does that mean? That now it means you have a surge of survivors in need of rehabilitation and recovery. Same thing happens in Baltimore, same thing happens at Maine Med. When people survive their trauma, you now have a community of trauma survivors that need recovery support. As these young physicians, we need to know about blast, right? That's the threat. Blast, penetrating, mechanical trauma. You have to review it, and then you have to teach your medics. And oh, by the way, you have to remind your command. We have to think about emotional trauma. That's why before you deploy, I was a division surgeon. So 9/11, I was a division surgeon. So deploy, first thing I did, so I gave the brigadier general my suicide briefing. Because as a major, I was on suicide task force, but you called suicide task force meetings after a suicide. So when I deployed, I sat down with a 1-star, gave him my briefing, and we developed a suicide task force to take care of everyone. Okay? Medical goes back to infectious disease. Where are we going? incidence of malaria, viral hemorrhagic fever. There was a high incidence of viral hemorrhagic fever when we first went into Afghanistan. And the poor wives at Fort Drum were seeing this on the internet, thinking it was biological terrorism, but it was indigenous, okay? TBI. Are you familiar with the ANAM yet? So, that's okay. 100% of your service members, sailors, airmen, Coast Guard, soldiers, Marines, everyone documents the ANAM, the Automated Neuropsychological Assessment metric. Okay? It's just, and here in Maine, the Maine National Guard utilized the ANAM and the IMPACT. IMPACT is used for high school athletics, right? So basically with the ANAM, now I'm getting a baseline, right? I'm not getting a personality test. I'm getting a baseline on cognitive function, okay? We all right with that? So now, you all have heard my tactical lecture, right? So when we talk about tactical combat casualty care, we're talking about a hot zone, a warm zone, and a cold zone, right? Any EMTs in here? Old EMTs? So as EMTs, remember we learned this from hazmat. This is hazmat, right? So in the tactical environment, hot zone is what? Dangerous. So best medicine in the hot zone is superior firepower, correct. Then hemorrhage control. And as you mentioned, safety, safety, safety. We're moving them out, right? We're getting them out of the hot zone. Good? Casualties, well, soldiers who are dinged, concussed, safety, safety for all the troops. I'll take your M16 now, please. So take the weapon, just arm, right? Right? Safety. You're a paramedic, right?
EMT.
EMT. So you're doing the ABCs in the warm zone, airway, breathing, circulation. You're not doing airway in the hot zone, because here's a light. There's a light there, right? You could be lit up, right? So airway, breathing, circulation is in the warm zone, and then we move to the cold zone, and we go to safety. Now, looking at that first linear battlefield, now, just a slide here to show you the jointness of the medical support on the battlefield. So we're using not just Army, but Navy and Air Force, okay? Simple, but more dynamic and rapid EMS. With excellence in EMS, you have a surge of survivors. Navy fleet hospitals, large. I never really thought about Navy fleet hospitals before, right? I never did. I always thought Air Force, Army. Navy fleet hospital, capable of handling 500 people. So you have these mobile hospitals, and we can talk about military operations, but these are the same concepts that you apply to humanitarian assistance. Patient movement via air, Navy, Air Force, small, open up the base. You have your combat search and rescue, you have your pararescue shooters, and then you open up with preventive medicine, family medicine, aerospace medicine, surgery in echelon 2, 3, expand, and all this is mobile, adding together. Again, main theme is excellence in EMS leads to a surge of survivors in need of rehabilitation. So I deployed 9/11, 9 months, came back home. Then I was at Walter Reed as a major during Desert Storm, but then came back as a colonel. And now we have to take care of ill and injured. There's a surge. Do you have that capability? Do Do you have the capacity? So that's why it's important to have civil-military collaboration, cooperation, communication at home, besides overseas. Okay? And as I mentioned before, that's why it's important for the physician to have good relationship with the leadership. So basically, I showed you a couple slides of the Navy, slide of an Air Force carrier. There are 3 ships you need to be thinking about as medical students as you move on to your residency. Do you know what those ships are? Care to know? So what you need to know when you're applying for residency, what you're looking for these 3 ships. You're looking for leadership, you're looking for good mentorship with the other residents, and of course you're looking for friendship. So that's what you need, that's what you're looking for when you start to interview for your residency. These are just, post-deployment health. I like to put websites in with my slides so people can explore, so they don't have to listen to me. They can just go back to the slides and do some homework. And oh, by the way, we're taking care of service members and their families. That's your job. I have the BIA website up there too. A lot of times in the emergency room, somebody's concussed and you say, oh, follow up with your family physician. But I like to say follow up with your state brain injury association. I believe Maine has 2 now. I know Massachusetts has 2. New Hampshire has a brain injury association. So this is a good resource for your families. Okay? Lots to learn. Back to the hot zone. When we deploy, we have some situational awareness that some people may think of as hypervigilance, but it's situational awareness. Other term, hot zone, sympathetics are a bit up for safety, safety, safety. Our goal, everybody's goal, military goal, law enforcement, fire, we want to come home to our families. We want to come home to safety. Picture in the civilian world with traumatic brain injuries, most of them are vehicular, right? What do you see up there? Talk to me. You can talk to me. So the reason I have this slide up here is, one, to make a statement. In civilian traumatic brain injuries, most are from blunt or motor vehicle accidents. Here, this is a board question. This is a basilar skull fracture, right? Raccoon eyes, blood behind the tympanic membrane. But the other piece, besides board questions, is mechanism of injury. When you look at this, I'm not quite sure, what do you see besides the basilar skull fracture? What comes to mind? Go ahead. Yeah, she had other bruising on her face. This could be domestic violence, right? Domestic violence, 90% of your injuries are where? Above the clavicle. So domestic violence, traumatic brain injury, frontal lobe again, going back to the frontal lobe, frontotemporal, going back to the orbital frontal. First of all, it's a difficult situation to return home. You've got to address safety. Then, with the injury to frontotemporal, right? Remember I told you about the sharing. Frontotemporal, contusion. Now, we have a challenge with executive function. How can she plan her escape? So, requires that team effort, right? Requires you to be thinking about that. She can say, I'm okay, but you need to have your team, social worker, physician, domestic violence, subject matter experts. And I think Lynn Daly is the subject matter expert here in Maine. She's in Augusta. So, again, when we're talking about TBIs, you know, a lot of people say, oh, you missed that mild TBI. Well, I missed the mild TBI in the emergency room because this is my differential. What's in the cranium? Right. Oh, you're going to be an ER doctor. Nice and simple, right? Brain, blood, cerebrospinal fluid, right? Now, from there, we tease things out. So brain, I'm thinking about blood, right? Obviously, above the clavicle, with that windshield, I got to be thinking about the cervical injury, right? And then I have to think about second impact syndrome. I want to do no harm. I want to secure the airway, right? Glass call of 8, intubate. I want to take care of the airway so that she doesn't lose the airway. I want to maintain perfusion, oxygenation to the brain. You're busy. You're busy. With TBIs in the US, about 1.7, 1.4 million a year, 80%, 80, 90% are mild TBIs, right? It's like a trauma that doesn't bleed. So there are 4 times in the US, the number of TBI survivors is 4 times that of HIV population. Blast injuries. When you review your blast injuries, again, blast injuries aren't going to go away. When you're thinking about blast injuries, the primary blast injury is blast wave. Blast wave, looking at imaging of the brain, corpus callosum, again, frontal. We're not really talking about the shearing, but we are talking about the shearing, right? Because you're not going to you don't stand there, get a blast wave without that kind of shearing mechanism, right? But with the blast wave with diffuse axonal injury, we are talking about corpus callosum, different kind of imaging. Different kind of imaging, different type of neuroanatomy, if you will. With the secondary effects of a blast wave, shrapnel. With the tertiary effects, now we talk about Europe being blown up. So the difference between Afghanistan and Iraq, so Iraq mounted, people riding, people in their vehicles, and Afghanistan dismounted, because dismounted, you're on foot, right? Different severity of injuries. And quaternary effects of a blast wave, anybody? The gases and the fire. One other piece, blast wave outside is a bit different from a blast wave inside. Blast wave inside, blast wave in the closed space. Just like chem bio, right? Closed space, greater injury. Blast waves, you know, from our WADM journal, from Pre-Hospital Disaster Medicine Journal in 2007, about 30% of survivors from these blasts have TBI, documented TBI. So it doesn't matter if it's Beirut, Belgrade, Oklahoma City. The TBI is something you will see in your career. Here's our challenge. So primary care physicians, here's our challenge. So the challenge is, how do we prepare for challenges? Organization. So this is a little reflect. What are you using? The DSM-5 or DSM-4? 5. So DSM-4, we're looking at the Axis 1 diagnosis, right? PTSD, major depressive disorders, anxiety disorders, substance use disorders, all associated with trauma. All associated with disaster, all associated with war and conflict. The personality disorders, the challenge, what was the patient like before the trauma? That's a challenge. Axis 3s or medical. So now we have a TBI, may very well have a chronic pain syndrome, may have cardiovascular disease. As osteopaths, we're always talking about tissue memory, right? He doesn't, you know, when I'm talking to him, I understand tissue memory. And I understand wearing a vest. So I don't think he has a cervical injury right off. I think he's been wearing a vest for a 9-month deployment and he's got trapezial injury, or trapezial tissue memory, or same thing applies to rape. So rape, piriformis, supraspinatus, that's tissue memory. OSA, what do you think about OSA? Have you had that yet? Have you had sleep? The guy over here is still sleeping. No. So sleep, you've had sleep yet in respiratory or in psych? So it's important to, when I talk to patients at the end of my review of system, I'll ask them, how are you sleeping? And then I'll go into a bit of a sleep history. And at that time, I talk about drug diversion or alcohol, right? I don't go, what do you drink? 6-pack, a fifth? Next question, you smoke? No. Sleep, by talking about sleep, is the best way to move on into your history of substance use. The part about obstructive sleep disorder here is that when troops were coming back home, many were being diagnosed with major depressive disorder because they didn't have linebacker necks, you know. So historically, you would think, oh, great big 18-inch neck, or BMI of 34. But taking the history, a good sleep history, and a good sleep study will help you treat the patient. The other part about treating the patient with sleep or with a CPAP, treat the CPAP and then titrate them off their other medications. Sleep apnea, did you have pulmonary yet?
Monday.
Monday?
Yeah.
Oh, what a good intro. So when Dr. Moakley's going to be talking about sleep apnea, do you give the sleep apnea lecture?
No, Steve Gorman does.
Oh, but when we talk about, think about it, just think about it. So going back to the dimmer switch with sleep, that's a good question. How is your dimmer switch? You know, most people will talk to you about sleep and drill down about insomnia. Do you wake up early? You know, I'm looking for depression. But think about, you're looking for something you can treat, right? And you can treat with a CPAP, and you refer to your sleep specialist, whether they're neurology or pulmonology, because you want a good diagnosis of sleep, the mechanics, the apneic incidence, plus they give you deep sleep, REM, a lot of information. It's not just do they need a CPAP. Then, as a prescriber, now you can start to titrate down as you treat their sleep apnea. Because what happens during sleep? What happens during apnea? It's a sympathetic surge. So why are you surprised that that patient is on hypertensive meds? And why are you surprised that that patient is on medication for GERD? Something to think about and take into your pulmonary system. The other part about sleep, chronic pain patients. So musculoskeletal. So OA-RA, oh my goodness, OA-RA, functionally you're doing pretty well. And when people talk about function, activities of daily living, a lot of times they don't talk about sleep. So sleep, what wakes you up? My knee, when I turn, or my shoulder, or my hip when I turn. So this is pain, sleep, dimmer switch. Challenging. So you have to help the patient, you have to empower the patient to move their dimmer switch from an 8 to a 10. You want that light bulb on. Again, I mentioned before, you know, when I have the ptsd.va.gov, I brought 10 nurses out to the National Center for PTSD back in 2009. So it was every day, 8 hours a day, graduate level training out at Stanford. And one takeaway was 60% of the patients with PTSD, post-traumatic stress disorder, will self-medicate. Then you have a challenge of finding good providers who will take care of patients with PTSD who are not sober yet. Challenge. For you as medical students, you have to understand each criteria, okay? And again, I refer you to DSM-5. With something to think about with trauma survivors, avoidance behavior. Avoidance behavior is a safety mechanism, but with avoidance comes isolation, and with isolation comes illness. You don't, now with the DSM-5, when we talk about post-traumatic stress disorder, we're not really talking about that spectrum of anxiety disorder. You may have hyperarousal, or you just might be numb. Okay? Going back to AT still, what's the message here? Message here is the rule of the Otter is supreme. Right? You've heard that before, right? So the rule of the Otter is supreme. AT still message. Rule of the Otter is supreme. Shock equals decreased tissue perfusion. You want to change that. You want to change that around. And, oh, by the way, motion is the lotion, right? So let me give you an example of an integrative team approach. I'm a consultant with the team, with the psychiatric continuity service. I'm a consultant because I have an operational background and a trauma background and a primary care background. So I see differently and I speak differently. So again, I talk about military history, then medical history, and my approach is military history, so I have credibility as a retired soldier, right? Empathy. Medical history, now I have credibility as a doctor, and I'm just entering talking about cardiology, like every doctor does, right? I'm talking about stressors, I'm talking about sleep, I'm talking about cardiac risk. You improve these cardiac risk, you improve neuro risk. This is an integrative approach, and it's patient-centered. They have coaches, dietitians, of course, subject matter expert, cardiologists. But you can do the same thing with pain. You can do, and they do. The Defense Veterans Center for Integrative Pain Management does this. So think about integrative pain management, just like you think about integrative cardiac management. Think about subject matter expert and coaches. Here with cardiology, with this approach, with the coaching approach, with the exercise or yoga, whatever's best for the patient, with the cardiologist, with the nutrition, with the holistic approach and making the patient a team member, they decrease the number of cardiac events and procedures in a number of patients with cardiac heart disease. Good example. Okay, I'm watching the clock. So I had mentioned this before, psychological consequences of disaster have been increasingly clear, and they include not just PTSD, but major depressive disorder, anxiety disorder, substance use disorder. I say disorder, I know I'm being live streamed, and there are people who don't want to say disorder, but I say disorder because now we have to talk about the impairment. Regarding the stigma of mental health, we just have to understand mental health like we understand cardiology. Right? Okay, so I was in Bosnia-Herzegovina. The background here is, I was in Bosnia-Herzegovina, and for the last couple of weeks, I don't know if you've been watching international news, but a lot has been going on at The Hague. In Srebrenica, 7,000 civilians were killed by Arkan's tigers. War crime. The background is 2,400 remains of these citizens. I think I use it as a background. As I mentioned before, the difference between a clinician and a technician is literature. So anybody remember Billy Budd, Herman Melville? So Billy Budd, Herman Melville, who in the rainbow can differentiate where the blue begins and the violet ends? So when we talk about mental illness, mental health, is a spectrum that we have to be aware of. It's not, we're not, and you don't even have films anymore, so I can't do that. It's not a good analogy. But it's not that you're not looking at a bone, a fractured bone. You're looking at a fractured soul, if you will. So more of a spectrum of DSM-5, anxiety disorder, PTSD. You have to have that awareness and that behavior and that empathy and that attentive listening. PTSD per DSM-4, post-traumatic stress disorder, you have to have the trauma. You do have the avoidance. Back in the DSM-4, there was more hyperarousal, more emphasis on hyperarousal, hypervigilance, higher state of sympathetic nervous system. With the 5 pays more attention to those patients with the numbing. Don't feel anything. I mentioned the arousal. The disturbance is important because when we talk about pain, whether it's back pain, hip pain, psychological pain, chronic pain, timeline, pain greater than 30 days, okay? And when we talk about disorder, we're talking about distress, and we have to address the impairment. What else? So with the DSM-5, A through H criteria, what is H? Nobody's going to remember this, but I remember it because I'm the president of addiction. So H is you have to rule out substance use disorder. Makes it very complicated. So, and oh, by the way, PTSD in theater or PTSD with PTSD from any trauma, why do you only have PTSD and not comorbid PTSD major depressive disorder? Makes it more complicated. So this is why we have to have good relationship, good communication with Dr. Montavani and Dr. Smith and other psychiatrists, because we don't have enough psychiatrists in the world, actually, besides Maine. We don't have enough psychiatrists and availability, right? So my public health piece here is that in the military, for military boards, if you will, if you're going to have a military board for post-traumatic stress disorder, only the military physician can address that. You can't get a civilian or a VA physician that says patient has PTSD, okay? In a way, talking public health, possible, probable, and confirmed. We don't have good SPEC or MRI. We don't have the neuroimaging now. You can go to Amen Clinics and look at his SPEC library, but we don't have neuroimaging that says patient has PTSD. We okay with that? We don't. OMT strategies, 1 o'clock now. So OMT strategies, so avoidance, again, my Air Force time was spent at the survival school. So I was the EMS director of the POW school and the base. So we had people living out in the bush that would come down to the emergency room at 3 o'clock in the morning because they're avoiding people. Same thing here in Maine and New Hampshire, upstate New York, Dakota, everywhere, reservations. The avoidance behavior. So the patient comes to you, good. Good. They themselves address the avoidance. Now, with your OMM, your OMT, you want to peel the onion, if you will. You want to get in. And sometimes when you peel the onion, it makes your eyes water, so you have to be prepared. So safety, they come to you for OMM. So you want to be dealing with the autonomic nervous system, toning it. I like soft tissue. I don't know what you all prefer. Soft tissue is non-threatening, right? Soft tissue is non-threatening. Soft tissue is non-threatening. We can talk soft tissue, you can talk ki, chi, craniosacral, but soft tissue is non-threatening. And I can let my fingers do the walking, right? So we understand tissue. That's why you're here. You're MD plus. So that's why you're here, to understand tissue as well. That's what you learn in OMM. So you're working with the autonomic nervous system while you're entering the patient. And as you're working your OMM, OMT, and doing your primary care, those intrusive thoughts, you're creating a safer environment for them to share those intrusive thoughts. And when I talk about intrusive thoughts, I'm talking about thoughts during daytime and during nighttime. You've had pharmacology, right? So you know the drug prazosin? Do you remember that? Are you second year too? So you remember the drug prazosin? So when a psychiatrist prescribes prazosin, why are they prescribing it? Good for you. Who said that? You're the man. So right. So when we prescribe prazosin, 1 milligram, 2 milligram, 5 milligram, I'm a family physician, so I remember mini press, same drug, right? And you mentioned alpha blocker. So 1 milligram, 2 milligrams, 5 milligrams. What I need to know as a family physician is that, did you have a good night's sleep with the prazosin? And when you stood up out of bed, did you get orthostatic? Okay? Because if you call it prazosin or mini press, it's an alpha blocker. So that's another thing, another teaching point. Understand how your drugs work. Dr. Mokler in Department of Pharmacology is going to teach you that, not pharmaceutical reps. And as I mentioned, I'm not getting paid by any pharmaceutical industry. Never again. Just something up here, just this one slide for you who might go into physiatry, neurology, or have patients and the physiatrist will say he's a rancho of something, she's a rancho of something. This is the Rancho scale. It's more sophisticated than that Glasgow Coma scale, isn't it? The point up here, when you're looking at Glasgow of 4, and here's another drug tip. When you're looking at the Glasgow of 4, that patient's not really a threat. He's not a threat to me, because I understand that he's a Glasgow of 4. I understand that. My job is to calm things down. And I choose what kind of blocker? Good thought. You're good. I choose a beta blocker, not a dopamine blocker, right? I don't want, what? Right, because I'm not, back 10 years ago, 20 years ago, people would go for the dopamine blocker. What does that do? We go back to the neurocognitive domains. Now I can't do rehab. I want to choose a beta blocker to address that agitation of the patient with a severe brain injury who is now who is now a Rancho 4. Okay, 1 o'clock. Most important slide. This is really the most important slide. This is from Thermopylae. This is my shield. I bear it into battle. It's not mine alone. It protects my brother and my sister today. On my left, it protects my city. I'll never let my brother or sister out of its shadow, nor my city out of its shelter. I would die with my shield before me facing the enemy. This is really what I think we all should be seeking. This is what military drives, that cohesiveness, that unity of effort, that unity of command, that cohesiveness. I need to protect and mentor the person to my left, the junior. This is good organization. Okay. First targeting wars of bridges. So behooves us to build bridges across these silos. So I hope when you graduate and you go out into your residency, you talk and you work as a team member and you build these bridges across your silos, because you really can't do it alone. You can't take care of your patients alone. When I first started medicine, you know, I'm in the emergency room, I'd run up to the unit, I'm thinking I'm intensivist, I'm not in, but now, don't be shy to talk to your colleagues and get your consultations, and don't be shy to take the consultation and do what's best for the patient. All right, that's it, 1:05. Any questions? You have to get to class. Any questions, comments, answers? So thank you all for being,
I got a question. So how are we doing, both particularly on the civilian side in treating PTSD and recognizing it?
Well, I think we have Dr. Mantovani here too. So the question had to do about when we're talking about post-traumatic stress disorder, Dr. Moakler had a question, how are we doing on the civilian side? So I've worked military, 28 years, VA, 2 years, now back at Walter Reed on psychiatry, 4 years. So I see the psychiatric continuity service as being a really excellent model. But again, that's active, those are physicians working at Walter Reed with multiple subspecialists and specialists, and of course a lot of volume. The question about PTSD, I think you should remember White River Junction is a site, it has a 10-bed site for PTSD. National Center for PTSD is a good opportunity for you to train. They are your best reference for PTSD, both civilian and military side. How are we doing on the civilian side? One, I think physicians need to understand the relationship between PTSD and other comorbid disorders. I think we have to go to Dr. Mantovani, Dr. Smith, for diagnosis while we're treating them in primary care. The other important point that you have to be thinking of is self-medication. 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 I think cannabis is going to be, for me, I'm not pro-cannabis with PTSD, because cannabis itself is a dissociative drug. And what you want to avoid in PTSD patients is that dissociative state. PTSD, make the right diagnosis, consult to have the right diagnosis. PTSD, comorbid major depressive disorder, PTSD of childhood, PTSD associated with the trauma, treating your tissue memory. Then, just like in substance use disorder with the public health emergency or the opiate epidemic, all epidemics need to be contained and controlled, so you don't have the access to good behavioral health folks who have good behavioral health teams. So PTSD, a couple drugs that have been approved via the FDA. Prazosin is really one of the best drugs. Again, I like to treat sleep. Sleep is on my to-do list for everyone. Treat the sleep, then they're better. The dimmer switch is better to do cognitive behavior therapy, and then interdisciplinary rehabilitation for their psychological trauma. Dr. Mantovani, do you want to add anything to this?
Hi. Well, I would like to appreciate how you address your concerns, because I think it's so important for the physician to have such a broad approach and to be aware of all the psychological aspects. My experience with PTSD is very different from the United States. because in my country, we don't have these military events, but our events for PTSD can be quite similar, since like we live in kind of a civil war situation, because we have the drug lords, kind of, if you guys watch Narcos in Netflix, it's very similar from what we live in Brazil. So some people who live in dangerous areas might have seen their relatives, a son or a mother or a father being shot by either by police or by gangs, war. So this is our reality there. And in my experience, 17 years in the emergency department, what I understand from PTSD, that drugs are very important, no doubt. They help, no doubt. There's a lot of abuse, especially alcohol abuse, that people are suffering, they are seeking for help. But I believe that PTSD needs a more global approach, that the psychological approach is so important, because it's usually what helps a person to get on track back in their lives. They experience a traumatizing experience. We can give them drugs to relieve the symptoms, but if we don't help them to understand, to cope with what they lived, then we won't solve the problem. That's my opinion.
Yeah, thank you. So go to ptsd.va.gov to study your PTSD, okay? Try to go to White River Junction during your 4th year. Try to go to any of the other centers. Also, go to Seeking Safety, seekingsafety.org. It's from Dr. Najavis, and that has to do with women who have been traumatized and alcohol recovery. Seeking Safety. It's really very good cognitive behavior therapy and a good reference. Now, Dr. Montevani talked about narco-terrorism, right? So ripple effect. Ripple effect in Baltimore, Chicago, other places too. Ripple effect. This kind of trauma, the more severe trauma, there's greater incidence of PTSD from trauma done to you by a human than done to you by nature. Okay? Then, oh, go ahead. Hi.
Hi, how you doing? So 2 things for the second years. One, I pronounced it prazosin, just so you know. We learned it in the cardiovascular system, but that was like a week and a half ago, so they've already forgotten that. Second of all, I apologize for coming in late, and I don't know if you've addressed this, but there's some talk about privatizing the VA. And I suspect there are some very critical specialty skills for the physicians in the VA that may not be appropriate or may not be cultivated as much in the private sector as in the VA, and I was wondering if you could talk about that for a minute. We'll filter out any swearing afterwards.
Let me be politically correct. I don't know. The VA has a very good purpose, But also with the VA, psychological health, NAMI, refer you to NAMI as well, National Alliance for Mental Illness, NAMI.org. Every state has one for you to network. The VA, I worked in Maryland VA. You are here in the New England area. New England equals VISING 1, FEMA 1, SAMHSA 1. My recommendation for you is to be engaged in VISING 1. The VA, I'm not quite sure. I don't think it's going to be privatized. My opinion. I have medical care at Walter Reed. My specialty my care at Walter Reed as an old guy. I go to specialty care at Walter Reed, but I also go to primary care at Fort Meade in Maryland. I have good access and I have a good internist. That's quite a challenge to privatize the VA system. And I don't I'm a physician, so I don't have much to say about that. I know that VA CHAMP was a challenge for funding. This I don't know, so that's all I can relate to regarding VA at that level. You trying to set me up for some? Okay, thank you. Any other questions?
Very much.